Hi, everybody, and welcome. Welcome to another Pilates hour. And I'm really happy to be back. I usually don't do them this close together, but thought we would talk today a little bit about low back pain. And I get this question often of, how do I work with clients with low back pain? What are the best exercises? What are, some tips and strategies and all types of things like that. So I thought today we would do a little bit of talking about it and then get into a little bit of movement. So I thought we would talk just a little bit about some terms. So we're going to go through acute and chronic and talk a little bit about that. Some different pathologies that we would commonly see in the Pilates studio, a little different than what you might see in the physical therapy clinic. Getting into asking questions. And when you watch Brent do his webinars, one of the most important things that we, as the person that's going to have some sort of intervention, can do is ask questions. We're going to interview the client or the patient, and we're going to try to bring out really important pieces of information. And hopefully, when we do that, it does a couple of things for us. It'll give us more information just of what do we need to do with this person. And it's also going to help us to know when we need to refer to someone with more experience. And that might be from a more novice Pilates teacher to a more experienced Pilates teacher, but it might be Pilates teacher to physical therapist. It might be physical therapist to surgeon or medical doctor. It never ends. Everybody is going to have a specialty, and they're going to refer on to someone that has a different specialty. So just want to go through that just a little bit as well. All right. So when we're talking about acute and chronic, just to bring, a little bit of information to the table, acute is usually something that is going on that is under or less than 6 weeks. And over 12 weeks, it starts to become chronic. And then there's that time in the middle. I've seen it termed as subacute or subchronic. It's almost like when we talk about pseudo closed chain, it's somewhere in between closed and open. There's that 6 weeks or so that's in between acute and chronic. That we know people in all of those stages. And again, just like any type of way to classify people, not everybody falls into all of these neat little boxes or neat little places. So it's just a way of thinking of, is this new? Is this something that the client may be just experiencing? We might work with that a little bit different than with symptoms or pathologies that are more chronic. The client is a little bit more knowledgeable about how it affects them, and probably has a little bit more information there. And the really good news, I guess, is that when we're talking about low back pain, most low back pain, I've seen statistics of 80%, I've seen 90%, it will resolve pretty much on its own. I was reading through an article that talked about exercise, and it wasn't very specific as to what type of exercise, but it said people who did move did better than people were more sedentary. So that's great news for us as movement teachers. That movement really is being, is helpful for people with low back pain. So it's probably going to resolve itself on its own. If it is something much more involved, like a really significant disc pathology, something where they might be having motor changes, where they're not, movement is starting to be impacted, or bowel and bladder control is starting to be impacted, that's something very different. That is where we as Pilates teachers would immediately be referring on to the person's medical team. If it's significant enough, they might even go to the emergency room so that they are getting treatment quickly. Luckily, we don't really see that so often in the Pilates studio, so we're not going to touch on that today. we're going to touch on the things that we really will see a little bit more. And then another term you might hear is recurrent low back pain. And that just means that someone has had an episode of low back pain. It's resolved. There's been a period of time where it hasn't bothered them at all. And then it comes back, right? And we have potentially, you've experienced that yourself. Certainly a lot of my clients have, oh yeah, my back is bothering me again. I hear that often. My back is bothering me again. And so we can start to look again at some strategies and things that are going to help with that. I just want to bring those terms up. So these are some of the things that I see often in the Pilates studio. You probably see the same, where people are bothered by one of these conditions, or they think they are. And we'll touch on that in a moment. So almost all of us have had some sort of strain or sprain. We've moved something that was really heavy, or we've moved with maybe not the best form, and we've had a strain, just like you might have a strain in your shoulder, your ankle, your knee, and it happens often in the back, and it's pretty common. And these are the types of conditions that really do go away pretty much on their own. It's bothersome. You might rest a little bit. You might modify your activities a little bit, but pretty soon, you've almost forgotten about it and you're back to doing what you were doing beforehand. Arthritis is a very common thing that we see. So making sure that we have our clients moving. I always think of Beth when I hear, motion is lotion, and Brent has said that before, and I've heard it in other settings, where movement for people who have osteoarthritis, movement is one of the best things that we can do to make sure that they are having the least amount of symptoms possible. And so getting in regularly to their Pilates classes and having things to do at home are really important. So that's what we often see. We see a lot of stenosis also. And depending on your client population or your patient population, you might have an older population, in which case stenosis has happened. And remember, stenosis, it's just a narrowing, right? We often will talk about that in the sense of cardiovascular vessels having stenosis. So the opening is narrower than it was in the beginning. And it is a part of aging. I hate to get behind that, oh, it's because you're getting older. I don't 100% believe that, but the body does change as we age. And some of these things we can't necessarily control by having, better diet or moving a little bit more. There are little bone formations, calcium formations, bone spurs. These things do develop, and that might be a cause of having a little bit less of a passageway for the nerves to move through. So the spinal cord, or the nerves that are exiting the spinal cord and innervating the rest of our body. And so that is something that does happen a little bit in an older population. And it comes with being able to, not really tolerate standing for long periods of time. You'll see people's posture change because it is often in the lumbar spine and sometimes in the cervical or cervical spine. I know there are people from all over watching, so I try to get my Z and Z in there. So it might be a cervical spine problem as well, where extension further closes the opening or the passageways. And so the nerve is now starting to have some pressure on it, and it's uncomfortable. And so we can do some things in the Pilates studio to improve our strategies, improve our posture, and improve our movement capacity for clients with stenosis. And it's quite manageable if we can catch it early enough. And again, some of the most important things is really not targeting the stenosis itself, right? Sometimes we think, oh, the client has this and I need to do something about it. You will, but as a movement teacher, I'm not going to go in and treat their stenosis. It's completely out of my scope of practice. And I personally, I don't know what I would do. What would I do with those areas where extension is bothersome? My skill set lies in getting rid of movement that is going to exacerbate their symptoms, which is further going into extension, and improving the two adjacent areas, which is the hip joint and the thoracic spine. So if I can get my thoracic spine to be more mobile, more and even more than mobile, I think the words like supple, where there's movement available. I'm not just thinking about, vertebra by vertebra, but I'm thinking of the entire thorax as being supple and able to make small adjustments without necessarily changing what's going on in my lumbar spine. I have that same capacity in the hip joint. So if I can restore hip extension, and for some people, they might not even be able to get to hip neutral. We don't know, right? But that's my thought. How can I get them so that they can have a more vertical, better aligned posture without immediately going into more lumbar extension? So that's where my thoughts going with somebody with stenosis. And very often it's very similar with somebody with a spondylolisthesis. It's also can be irritated or aggravated by extension. And so I want to start outside of that area and try to get them to have more suppleness, more movement, and better awareness of those areas so that they can be, again, more vertical, more in the position where our bones and our joints and all of our tensegrity system really is at its best, and not in some of the postures that we adopt to get out of pain. The body, it's pretty smart. It wants to not be in pain. And so we adopt these postures. And so you'll see that often with people who have extension sensitivities is they become more and more and more flexed because it feels better. The problem is not doing that periodically as a rest or as a strategy to just get rid of some of the discomfort and then be able to come back out of it. It's when it becomes our permanent posture. And so these are again, I'm thinking of these ideas of how am I going to do these little doses of better posture, these little doses of exercise, so that we eventually can get the person back up to whatever their optimal is. And it may not be the optimal that you see in the anatomy books or in, a poster of here, this is really good posture. But for that individual, can I improve it? And it may take some time. These things don't necessarily change really fast. Sometimes they do, but we're in it for really for the long run and the long change. And then disc pathology. I probably don't even know if I have a client who hasn't told me, oh yeah, I have, I have a herniated disc, I have a bulging disc, I have all the different, insert the term that's associated or they've associated with their disc pathology. And quite often there is some disc pathology present. You might look at an MRI and they've shown in studies where they've taken people who don't have any low back pain symptoms at all, and they have done imaging with them, and it shows different things. You might see some stenosis. It might show a little bit of a disc protrusion. It shows all kinds of things, bone spurs, yet the person doesn't have any pain. How can that be? So we've gotten very good at the causation, right? I have back pain. My MRI showed that I have some sort of disc hernia or whatever the word is, protrusion, bulge. And so clearly this disc pathology is causing my pain. And they've actually shown that that's not true. The two things are existing together, right? We talk about causation and correlation, right? They just happen to be there at the same time. So I think, and again, this is my opinion, shared by many, but this is my opinion, that most people who come to us and say, I have a disc pathology, they might, but it might not be associated with their pain. So just something to think about. And this is where our communication skills are really important, because we cannot go into this being dismissive, or I heard on a webinar once that you don't actually have any problem. We can't say these things, certainly not in that way. But we can slowly start to educate our clients of like, okay, well, let's see how far we can get. Let's see what we can do to improve, the situation. And usually by then, they're so happy to have better feeling movement just throughout their day. They can get through the things that they need to do without so much discomfort or any discomfort, that then they're open to listening to some of these things, because our beliefs and what we've been told do help shape us. And we wouldn't want to just come in with a bulldozer and say, well, everything you know is false, and now I'm going to show you all the stuff that's, that's true. Because again, I don't know that. I don't know that 100%. But my inkling is that you probably can move better, and you're going to have less discomfort. And whether it has to do with the disc pathology or not is almost not important for my level of interaction with my clients. So that's just something to think about. And and before I show the next word, I know most of you could answer this if we had done a Mentimeter, like what's the cause? What are we seeing that, could be in somebody's hip or knee or ankle or shoulder, and especially in the spine, is their poor strategy. So again, that is where we as Pilates teachers, when we are working with clients and able to give them better strategies, we are worth our weight in gold or whatever, platinum. It's really significant, the amount of change that we can create in people, not by addressing any of these pathologies directly, but simply by changing their strategy. And it is huge. So I mentioned this of asking questions. One of the most important things that we can do is ask questions. So we often won't, and again, this is a little different for a Pilates teacher than potentially for a physical therapist. We're not probably going to see people in that very, very acute stage. Sometimes we might, but a lot of times they're going to stay home. They're going to call. It's like, I can't come to my session today. I'm really in a lot of pain, and I'll see you next week. So quite often in the beginning, we don't get that interaction with people. A physio might, a chiropractor might, an osteopath might. And that's when you might be doing, if that's where you have your interaction with people, a lot of the kind of biomechanical counseling. You're making these decisions of, is it better, to rest? Is it better to move? You're going to be the one saying, gosh, this seems fairly serious. I'd like you to go see your physician. I'd like you to go see somebody in the medical field. This is where that is often happening. When they come to us, it's been a few weeks. It's still in the acute phase, but they're coming back. They want to come back to their classes. They want to come back to their sessions. And this is our opportunity to get information, right? They might be a little bit nervous about it. It's okay. Just tell me what happened. Tell me a little bit about it, without getting too much into the, oh my gosh, I heard you had, because we don't want to start leading people into catastrophization or really amplifying what happened. We just want to know. So in those, middle weeks, that's a great opportunity to come in and show people that movement can change how they feel. And it will hopefully prevent some of that chronic pain. You've heard Brent in when he does some of the case studies of people who've gone in this chronic pain for so long and not really gotten very good information. They start to amplify their story, not at a sound level, but at a, it starts to get a little crazy sounding because no one is listening to them or able to help them. So if we can get in and say, hey, you have this, we're going to do some movement, and you're going to experience feeling better, that's great. Then we hopefully can prevent people from getting to that place where they're feeling like they have to really yell about their problems. So tell me what happens. Start to get information. What is, is there anything they can't do, right? Because they are getting in their car, they're driving to see you, they're getting in and out. Maybe they're not driving, maybe they're taking an Uber, or they're on the subway, or they're on the tube, or however they got there. They were able to get up, get dressed, get their shoes on, gather their gear, get out the door, sit down, get back up. And so they're okay, they can move. And sometimes when clients come in and have been telling us, or we've heard, wow, they've had a case of low back pain, we get a little bit nervous, and that's okay. That's like getting nervous before getting on stage. It makes us a little bit more aware. And though we don't want to coddle and baby people when it's not needed, when it's not necessary. So just something out there for those of you that are newer teachers. It's okay to have that little case of nerves, but then just ask the questions and remember that they got here, right? They walked in the door from the parking lot. And if they didn't, if they all of a sudden are using a walker or a cane, or they're having somebody assist them, that might be the time. Even as a seasoned Pilates teacher, I might go to one of our physical therapists and say, hey, can you come out here for a moment and just do a little bit of questioning at the beginning of this session to make sure that it's okay for me to work with this client. But you can start to find out, what do they need to do? What do they want to participate in? What are the activities that they normally do that they can't do now? Or it's just a little bit more challenging for them to do their activities. And again, we're thinking really about work, recreation, and our activities of daily living. And then start to find out, maybe you ask it just as a blatant question, or maybe you're just kind of forming your questions to gather some of this information in a little less direct way of, is there something that makes it better or decreases their symptoms? What would that be? And you're going to start to understand what their beliefs are. And I specifically bring this up because what we are trying to always with our clients, whether they have some sort of pain or dysfunction, or they're the average client that just comes in because they love to do Pilates, is we want everybody to have their own internal locus of control. So I am responsible for me. I'm not being guided or directed or influenced from the outside. That's kind of tough in today's world with all of the social media that we have, but I can control myself, and I've figured out how to move, how to do things so that I have less pain, less discomfort. So I know if I rest for 5 minutes, if I have to walk a lot, then I can keep going, right? So that might be something that is my own awareness of, yeah, if I take 5 minutes, I'm good and I can keep going. I do a little bit of rest, or if I keep moving, I'm better. It's when I sit that I have more discomfort. So I know that my positive, my thing that can make it better is to continue to move, right? Or I use ice periodically. Those types of information, those pieces of information can give you quite a bit of like, do they think this is their responsibility, or do they think it's somebody else's responsibility? Well, I hurt my back at work because my boss does such and such, or my job dictates this, right? You've heard people say that, and you've heard Brent talk about that. So I really want to know what's behind this. Are they thinking they're, actively able to search and find things that are relieving factors? Or are they just like, yeah, it hurts, I can't do anything, it's just how it is? So again, just starting to build the picture. And your clients, a lot of the people that we're going to see, we know them. They're not new people who think, I have low back pain now, I just hurt my back, I think I'm going to go to Pilates, right? It happens, right? All of these scenarios happen, but most of the time it's our own clients who are going to come in and say, oh my gosh, I was moving some flower pots around and wow, my back is really sore today. What can we do? And that's where we have that great in, because they already know how to move pretty well and we can change things quickly. So I mentioned this already. What other bits, do they know about it? Is it better to move, better to rest? This is where we, as practitioners too, can get a little bit of information, and probably more in the very acute stages, in the very new stages. I remember having that flower pot moving incident, and I'd never really had any low back pain, nothing that lasted more than a day or two. And I pushed a big pot on my patio and I pretty much couldn't walk, breathe, bat my eyelashes. It was incredible, the pain, but also that inhibition that I got. It's like, not only could I not move, but I didn't want to move. And it felt like I shouldn't move. And so when we're thinking about stages of rehab, if you've gone through the Polestar training, you've heard about the stages of rehab, and it's our opportunity to really find out, does movement need to happen? And movement is what is indicated, or are they a step before that where actual rest is needed? And it'd be the same of, letting tissues rest and heal. You might put a cast or a splint on another body part. It's a little harder to do that in the spine. We don't do that frequently. So our job as a therapist or as a Pilates teacher might be, hey, we're going to do some movement at the hips and the shoulders. We'll just let the spine be for now, and we will do more disassociation exercises and see how that goes. And that might readily, in the same session, lead to movement. But that would be our place where we could start with those stage 1 movements of disassociation, let the tissues heal, have a little less muscle guarding, and then move on where we might just, very, very slyly introduce a bit of a pelvic lock. Just let your pelvis tip back a tiny bit and tip forward a tiny bit. How is that? Yeah, that's okay. And then you might have an end to getting into some bridging or something like that. So what do they do as they're walking in? And I'm a little jaded because we used to have a lot of in California, when I worked with Brent in his physical therapy clinic, we had a lot of people coming in for workers' comp. And the majority, I would say, were legitimately, I got hurt, I need to get better, I want to go back to my job. Everybody was on the up and up. But every once in a while, there were people who were trying to, work the system a little bit. And we'd watch them walk across the street and they'd walk over and they'd doing whatever. And then they get close to the door. And then all of a sudden they can't move. They don't know that we're watching them. So you can, again, our Pilates clients probably don't really fall into that, but it is something to be aware of. How are they before they get in? How are they when they get in? Are they seeking a little bit more attention maybe than they need? And again, we will fulfill that role of giving it, but also regulating it so that they are a little bit more in touch with what their condition really is. And it's not as scary maybe, or not as bad as they might think that it is. And that's legitimate. Some people have not had an injury before. And the first one, it's a little bit scary. And that fear of movement is huge. Every time I bend over to put on my shoes, I get this sharp pain in my back. After a while, I'm not going to bend over that way. I'm going to find a different way to move. And so we have people who are very fearful to move. And this is where the equipment especially can help us. And then you have the people who are like, yeah, forget it. I can't be bothered. I can't go gently. I have to go full bore. So again, we have this opportunity to regulate a little bit and show people how to do a little bit more, how to do a little bit less, and then make sure that we're turning that responsibility back over to them. That's the really important key part. I mentioned already, is it something related to their activities of daily living, getting dressed, driving, combing your hair, things like that? Is it work or is it recreation? So important to know those things. So we're able to approach whatever they need to do. And I'll say again that trust your gut. Most of the time when you're working with a client, it's appropriate for me to work with this condition or it's not. And at any point when you feel like I just don't know enough, I really don't know enough about this, and I wouldn't want to hurt somebody, that gut intuition is strong. Trust it and get some guidance, get help from someone else, from somebody who knows a little bit more. And if you're in a Pilates studio that doesn't have physical therapists or doesn't have any medical practitioners, go to somebody more experienced than you are. Let them help. They'll be able to have a little bit more perspective. And then, referring out is great. And we typically do something where we give a few recommendations. Here are 3 different physical therapists that we've worked with in the past who are quite good, and you can choose. And that takes away, any type of, well, the person you told me to go to, I didn't like them, or I didn't get good service from them. So provide a few different practitioners and let them choose, or if they have their own, certainly they can go to their own. But trust your gut. It's usually spot on. All right. So how do we really improve strategy? So a lot of this is that positive movement experience. And we're at Pilates on Tour out in Arizona, the Rehab Summit. And it was talked about a lot of how can we get people to have these positive experiences. And we talk about it in terms of, again, of locus of control and self-efficacy. When we give people those positive movement experiences and we teach them what we were doing to get to that point, that is where it becomes really strong. I'm going to show you how to do these things, and then you're going to do it. And I'm going to give you some feedback. You're going to start to develop your own internal feedback, your own proprioception, to know about things like posture, to know about movement. What is the better way to move than how you're moving right now? And how do you check that? Right? One way is to grab your phone and video yourself or take a photo of how you're doing things. Later, you'll be able to look at it and say, this is what was videoed at the Pilates studio where I had really good form. This is what I just recorded myself doing. Now I can bring those things into a little better alignment. So anything that can help build that. And that's true also for how much somebody does or how much they continue to move once they start to get some of their symptoms, maybe of fatigue or a little bit of discomfort. We need to teach people to listen to those things. And again, have that next step. What do I do if? And then keep moving forward, because that will allow them to be in control of their own bodies, as opposed to us saying, oh, you should only do 10 repetitions, and they do 8, and now they have discomfort, right? They need to listen to their own bodies, and it's our job to have that conversation with them so that they can start to understand that a little bit more. And the frequent intervention is what's really important. An hour or 2 of Pilates a week is great, but it is not going to be enough to really change someone's how they move, their patterns, their strategies, all the things that they do in their day. 2 hours a week is not enough. So we need to make sure that we are really giving people this whole body health and commitment idea from Joe, the real lifestyle of Pilates, where every hour they do a particular movement, or maybe they go and stand against the wall just for a moment to check their posture. Maybe they do they're getting back to doing things like getting up and down out of their chair. So they start maybe with a cushion, it's a little higher, and they do 5 or 6 repetitions, or maybe they start to build up to 10, and then they go a little bit lower. So we're starting to play around with load and load modification. Maybe they do something where they hold on, and then later they don't hold on. So all the time giving them some strategies so that they are able to frequently start to change their nervous system of how they are moving, how they are feeling. And that also helps in their belief system, because belief that you're going to get better, that there's hope, that there's change, that is much stronger predictor of people getting better than hamstring flexibility, glute strength, core strength, right? Oh, I've got to strengthen my core so I don't have back pain. Really? Are we still saying that? Yes, maybe having some better strength or power in your trunk might be helpful. It's not what we're saying. It's that I'm not relying on that, right? It's not just that. I need to work on whole body movement, whole body strength, whole body mobility, so that I have all the options necessary, so that if I'm doing something that's more mobile, I have that capacity. And if I'm going to pick up something heavier, I need to push or pull a piece of equipment, I also have that ready to go, right? And I'm able to adapt to whatever the situation needs. So that belief is really, really strong and going to be much more important and a belief predictor than any type of the physical measures. So that's where we have a really good in with our clients. So, all right. Oh, I was just going to show this, and we'll put these bits of information in the email that Melissa sends out. So just saw another study from 2022 talking about Pilates as a form of rehabilitation. So it's great. We, never thought, 20, 30 years ago, when people couldn't even pronounce Pilates, that we would get to the point where it is being so researched and it is coming to the top of a lot of these studies as a really viable intervention for pain and for disability. So just sharing one more that I stumbled upon, and we'll put the links to these in the email that Melissa sends out. All right, so last slide, and then we're going to move a little bit. So one of the things that comes to mind, this very key Polestar phrase of distribution of movement equals distribution of force. And we were just with our US faculty, and then also some faculty from our licensees and international community. And I heard two great different ways to describe distribution of movement equals distribution of force. And one was talking about, and this was Archana, who's in near Atlanta in Georgia, and she was talking about runners. And she said, look, if I had to run for 26 miles and do a marathon, by the end of that 26 miles, I'd be really tired, right? And she's a runner, she would know. But what if I had 25 friends and I ran a mile, and then somebody else ran a mile, and somebody else ran a mile? We'd have all of that done, but no one person would be taxed more than another. And I thought that was a great way to think about distributing movement or distributing force. And another was Gary. He's from Polestar in Hong Kong, but lives in Canada now. And he described it as a factory, like the factory workers. And if everybody's going along, doing their job, everything is going well. But what if some workers have to work more than others, or they're getting very tired? And, we have this disruption where now other people are doing more than their job because these people can't do their job anymore. And you can think about it as real life situations of how we can distribute movement and force. And I thought those were two really nice ways. So thank you guys for sharing those. I wanted to share with all of you. Improving hip mobility. This is one strategy that is universal for a lot of people with back pain, knee pain, ankle pain, even shoulder pain sometimes, is a lack of hip mobility in all the different directions. Thoracic mobility, especially extension, but really in all directions. So we talk about extension because we tend to be so forward in our daily lives. But if we can get up and get moving, rotation helps me look around. It helps me move. I combine side bending with a little bit of twisting to reach for things. Even my breath capacity is changed or enhanced by having better thoracic mobility. So those would be some things that I would look at in your program. So breathing exercises and focusing the breath, using the breath as a tool. If you're in a position, breathe more in that position to see if you can get the breath to help with the mobility again, or the suppleness of the tissues involved. Think about and talk with your clients too about any patterns they have of holding. And I notice this in my own body of a lot of times I'm sitting, I'm at my desk, I'm just doing whatever, and my right whole thigh and hip flexor area is just on a bit. Doesn't really need to be. I'm not really aware of it. But as I start becoming more and more aware of it, and it's like, oh, right, I wonder why that's happening. And I have the opportunity to let that go. So again, awareness, proprioception, the more you're aware of something, the more you are aware of it, and you can make change based on those things. And then one thing, this is something that Christy and I talk about a lot in terms of movement and being curious and allowing clients to figure out their own ways to move. This also comes in a lot in the Feldenkrais world. So how are you exploring movement and seeing what works for your body? So if you are a teacher that has pretty hard and fast rules, like this is how it's done, we don't do it a different way, you might start exploring letting the client figure out what is the most comfortable way, the easiest way, the most fulfilling way to do a particular movement, because they do know their own bodies. And most of the time, if you give them an option of how would you do this in the most comfortable way, they will figure out, and it may take even in that moment a little bit of exploration, but they'll figure out how to do it. Yeah. So it's really giving back to them and giving again that sense of internal control. I'm not relying on you, the teacher, any longer. I now am empowered to find the way that works best for me until I get back. And then maybe you use those variations that were challenging in the beginning again to challenge them now. And one other thing, and I didn't get it onto the slide, but thinking about how we are using the equipment versus using the mat work. And this could be with any client, but especially important when somebody is coming in with low back pain. And we do want to start with some disassociation exercises, something where the torso is fairly stable. We're not really moving the body too much, but we're looking to have movement in the hip joint. That's going to tell us that some of the buttocks and hip muscles are not over holding or guarding, right? They've let go enough to let movement happen in the hip joint. And you will often have an easier time of that on the equipment than you will on the mat. The mat doesn't have any assistance usually, not in the same way that jumping onto a piece of equipment that has springs or pulleys does. That's going to give more support to the body. So I often will find people starting on the mat, and it's okay to do it. But know that if you're trying to get somebody to do this, even some basic femur arcs, and they have pretty low awareness, low trunk control, and maybe they have a little bit of stenosis or they have a little bit of something where if they go into extension, it's uncomfortable. They're associating potentially lifting their leg. And if they can't maintain their body alignment, they're probably going to go into extension. And it's going to be that cycle of every time I do this movement, it hurts my back, it hurt it again, it hurt it again. Where else could you do a femur arc, right? In a position where they're not going to have that same reactions. Jump onto the equipment just for a second and go through a couple of movements there. And they're basic movements that we see. I just want to relate it back to what we're talking about. And then I do see there's a question and I will answer that as well. So footwork is often the first exercise we give to people. And on the reformer, it's wonderful because again, you have so many different ways to adjust the bar and adjust the body. I will often put a cushion, prop the headrest up, do something. Again, when somebody's come in quite a bit of pain, to nurture the body. We don't necessarily want to feel like the head is falling over backwards. So prop the head up, make it feel comfortable. But do start experimenting with how close the foot bar is, so that we really are starting to mimic the deeper squat of getting up and down out of a chair, which often is difficult for people. The buttocks muscles are quite switched on. We don't have a lot of mobility there. And going into footwork can be that moment. So I hear a lot about 90 degrees. It's kind of a magic number. I'm not quite sure why, because so many things that we do require us to be in greater than 90 degrees of hip flexion. But it's kind of like it's the it's the moment where 90 degrees is the right place. And it might be for something like footwork. But it might also be fine to have the feet a little bit closer, as long as the person can maintain their body position. So keep experimenting with that as you're working with your clients. Farther and farther away is okay, except the farther away parts of the body are, sometimes the harder it is to control. Also, it's going to diminish the spring intensity. So as you scoot the foot bar closer, the springs will feel heavier, because you're now going back a little bit farther, and stretching the springs a little bit longer. So just some things to think about in the beginning of teaching. Making sure also that we really are emphasizing the bone rhythms, or the arthrokinematics. So as I bend, I'm really thinking about internally having a spiral out at my thigh, even though my knees are going to continue to point to the ceiling. And I can either think about my pubic bones in the front narrowing together, or I can think about my pelvic, my sitting bones and my pelvis widening. So it's closing in the front or widening in the back. And that alone, just that cue, is something that takes us out of this motion, where I am now really not allowing much motion in my hips. There's quite a bit at my knee, and I can't fully straighten my legs unless I let this go, or I arch my back a little bit, which is not going to be so comfortable for people. So just some ways to get into that motion a little bit more. And then thinking about feet and straps, and I was just again watching some people at the conference last weekend, and they were doing feet and straps, and the instructor was saying, allow your legs to come all the way down, get horizontal. But the number of people who kept their legs at about 45 degrees or so, and were really hesitant to allow their legs to come any lower, I thought, well, that's really interesting, because one of the things that I focus on is teaching people how to get their legs lower. And if you just say, put your legs lower, they're not going to probably have the best strategy. The other thing we do at that moment is, now I want you to be really careful. Of what? I've heard teachers say that for probably every exercise there is. Now, I want you to be really careful because of your wrists. I want you to be really careful because of your back. And think about, well, what are they interpreting with that? Am I going to get hurt? Is it going to hurt? Am I going to injure myself? Why are you telling me to be careful? I thought this was a safe, lovely environment. So be aware of what you're saying and how you're saying things. Because to you, it might just be, oh, yeah, be careful, just stop before it bothers your back. But to them, they might be interpreting a very, very different thing. So I'm going to go feet in the straps, and then just talk through that a little bit. And then I see some questions, and we'll get to answering those before we finish up. We can still have the same idea of the arthrokinematics, or the bone rhythms of the movement. So as I allow my legs to come up, I can be thinking about widening a little bit at the back of my pelvis or narrowing into my my pubic bones. I can think about maintaining a little bit of weight at the back of the rib cage. And then to get down low, push into the straps as if you're standing in the straps. And with that intention of pressing, people will be able to figure out what to do in their body, not by telling them to engage their abdominal muscles, but by giving them a task to do, which is to push through the straps, push through the legs, and automatically the body figures out how to maintain its shape. Better than if we scare the client and tell them to be careful, or we just say push your legs down, in which case I'm probably going to do something like that because I don't know any better. So this idea of co-contractions, or we talk about bandhas, these like groups of muscles around joints. This is another way of getting that to happen, the sense of standing. And how perfect is that? Because they're going to have to stand up and walk out of the studio. So it's a great way to bring that awareness to their bodies. Oh, great. So Barbara's asking about Fryett's Law. And I can talk about the law that we use the most. So it's Fryett, and it talks about available motion. So these were studies that looked at spine mechanics and spine mobility. And the way that we talk about it is looking at the available range of motion at any vertebral segment. So this segment to this segment is going to have this much flexion, this much extension, side bending, rotation. And as we take up that available movement in a particular direction, so maybe I go into flexion, I might have a little bit less range of motion available to then add on rotation. And this becomes important when we're thinking about combined ranges of motion, right? So I might see a lot of motion in spine stretch. I might see a lot of motion in spine twist, but when I have somebody do the saw, now it's combined, right? I want to be mindful that I'm not pushing them beyond what they can do because they only have so much range of motion. I need to be respectful to know that probably both of those are going to be a little bit less as they combine it together. So it's a way of thinking about available range of motion. It also comes into play, and I might have mentioned this in the mermaid Pilates hour, is when we are looking at faulty movement. So if I start mermaid in this slouched position, I'm going to have very little ability to actually go into side bending because there's just no motion left. And that's one of the reasons why in a lot of the sitting positions, we have people sit on something so their spine can be more vertical. And now they have access to all the motion that they really have instead of taking it up by being in a poor alignment. So those would be the two ways that I would talk about that. Thank you, Barbara, for asking the question. Patricia says she has a friend with a lack of mobility and trying to help her in the beginning of training. What's best? Okay, good. So I did touch on this maybe after you asked your question. So if it's a choice between equipment and mat, of course you can start wherever you like, but consider starting on the equipment with very basic movements like footwork. Right? If you have a trapeze table and there's no reason why they couldn't push their legs up in the air, you might think about doing footwork on the trapeze table. You could have different exercises on the chair because you're going to get support. And sometimes those movements are in a different orientation to how that motion normally goes. We talk about a different orientation to gravity. So if they can't do a squat comfortably, it might be that they can't. It might also be their strategy is so poor that lying on their back and doing footwork, now they don't bring with them the same poor strategy, and you have a chance to get in and do some movements there. And we can uncover a lot of ability, a lot of mobility and control when we offer a little bit of assistance. So it's just interesting how things like that improve by adding some spring help in the beginning. Great question. Thank you for asking that. James, what would be the main reason a client would use a Pilates teacher instead of a physio? Why would they use us over them? Well, that's kind of a loaded question. I would never say don't go see a physio. So hopefully you didn't take that from me. But a lot of times it happens when somebody is an existing Pilates client. They maybe don't have a relationship with a physio, and they're coming in to do Pilates, and that's the next time they come in, it's like, wow, I have this particular, low back pain or knee pain or hip pain. And we're often the first line of somebody having an intervention. And that's where I say it's really important to know where our place is. If somebody came in and, had really excruciating pain, I probably wouldn't work with them that day. It wouldn't be appropriate for me to work with them. But if they had some, again, pain that wasn't so severe, nothing was really provoking it, and they reported to me that movement was a little bit helpful, they did feel a little bit better when they were moving, then I might put them on the reformer and give them some footwork and see how they did with something like that, as, again, a first line of defense. And then I can make a decision of, I think we can continue with movement, or you can go and see your physio, or here are a few other, physios that are in the area that you could go and see that we've worked with to make sure there isn't something else going on. But a lot of times it really is strategy, strain, sprain. They've just overdone something, and giving them some assisted movement and some homework is actually going to be great. And they probably don't need the physio. They don't need your level of care. But I would definitely always keep that, as an option, because I want to make sure that people really are getting the best level of care that they can. And we're pretty darn good movement teachers too. So that's a cool thing that happens. So thank you so much, James, for asking that question. I am aware of time, but we just have two questions here, or maybe a comment. Oh, now there's more. Would you share your layman's term on explaining to client? Oh gosh, Sam, I don't know that we have. I'll put some things in the notes about that. I don't know that I have enough time. It's already a minute after, but I will answer that question for you, Sam. It's talking about the whole pain science and how pain works. And I'll just say that pain is not bad. Pain is a signal that something is happening, and we need to pay attention and make change. When it becomes chronic pain or centralized pain, that's a different piece. But I'll put some things in the show notes that will go out in Melissa's email. Is it okay to work on and on only on the mat with somebody after a total hip replacement? Sure. Again, Natalia, I would make sure that you're talking with their physio or their physician to make sure that you're doing things that are in line with what is okay for them. Make sure they can get down and up off of the floor, things like that. But a mat-based program, should be okay as long as you're following the physician's the guidelines. Lisa wants to know about the bone rhythms. With the squat or when bending, when you're going into hip flexion, there is a relative outward rotation of the femur and a relative inward movement of the two sides of the pelvis. Now, of course, that's not happening. It's the arthrokinematics. It's what's happening in the hip joint. But that's the direction. So if you were going to squat, you could think of the femur spiraling outward and the pelvis spiraling inward. If there's any more questions that anybody asks, I will certainly answer them in the notes the best that I can. Thank you so much for joining. We do have some things on the schedule. I just want to make sure that you're aware of them. We have the Franklin retreat that's happening at the farm, where both Brent and Eric are going to be teaching. Eric's doing a course, and then they're doing a jointly taught retreat at the farm, and that is May 30th through June 2nd. It's going to be fantastic. I'm going to be there. I can't wait for it. And I am teaching a transition intensive. Sometimes schools call it the bridging program. I am teaching that in Newport Beach in Los Angeles in August, the weekend of the 17th and the weekend of the 24th. So it's 3 days, some time off and 3 days. And you can get information on both of those continuing education events on our website. The transition course is great for just upping your skills, diving a little deeper into the material. If you're a Polestar grad, it's great to catch up on what's new. And if you're not a Polestar grad and you want to know more of this, please come. We want everybody to come to that who's comprehensively trained. And then we have our ongoing comprehensive courses. So we have a new group that's starting this summer. So if you are watching and you're interested in going through training, check out the website and you can get the dates for the upcoming comprehensive course. All right, everybody, have a great rest of your week. Thank you so much for joining, and we'll see you next time.